Well, we're back. You thought that we'd gone, but we hadn't gone. We just took a little pause. It's been about 2 months since we last did one of these COVID-19 updates. And before we get to the COVID stuff, a little family business just sort of to begin things. First of all, as probably many of you have heard by now, our friend, our colleague, our mentor, our spiritual advisor, Billy Mallon had a very serious thalamic bleed at the end of September. He was in the ICU for a long time. Jan, his partner, is with him, getting looked after by Peter Vecellio and Rolly, and got out of the ICU. He's been in rehab for about a week or so, and he should be coming back to LA later in the week. But our thoughts are with you, Billy. He's just such an amazing guy. He's been so important to emergency medicine for decades. If you want to help out, there is a GoFundMe to help Billy out with what's going to be some pretty substantial expenses for cars and getting his house accessible. He, in classic Billy fashion, was having a stroke and made the diagnosis and actually called 911 before he became aphasic. He's able to speak again now, but his right hemiplegia is pretty severe. But Billy, we'll be seeing you soon, okay? Here are some pictures actually from last year at ACIP where we released CorePendium. We had a big non-profit event as well, and we had a great time. It's hard to believe this is a year ago. You look at these pictures and you're like, why are you people not wearing masks? Why aren't you physically distancing? So a lot of bad things have happened in 2020, but some good things have happened. So Talon Hidayati, who is a former resident at USC that we all know so well, Talon was actually Speaker of the Year for ACIP for 2019. So congratulations, Talon. She was an amazing resident, and she's now amazing faculty at Cook County. And Chris Corwell is also a big part of CorePendium, is ACIP Faculty of the Year. So congratulations to both of you guys. That's really well deserved. About a month or so ago, we put on our first pediatric conference, and it was a great success. And we got some awards to give away from that. So we asked everybody who was the most engaging speaker, and Richard Cantor won. I don't know how he won this because he was in his basement and he won. And here it is. Rich, this is coming to you. It's very expensive, but it's coming your way. I have an award for the GOAT, the greatest studio director, and that's to Graham Smith, who's behind the glass right now. He is the greatest of all time because for 3 days he was in the smallest of rooms and ran our entire conference. So this goat's for you, Graham. We've also got one here, and this one is, I can't see my slides, but one went to Eileen Claudius for putting the show on. She did most of the lectures. She wrote most of the lectures. It was really amazing. So thanks, Eileen, for doing that. And I've also got here the most engaging session. So basically the best lecture was given by Britt Guest. Britt, you won this. Everybody thought you gave the best talk was on emergency delivery. So there you go. Pretty impressive. So let's now get to COVID because this is pretty important stuff. I'm going to show you this slide here. This is the Washington group and their projections, and it shows that COVID is increasing pretty rapidly and could really explode globally in the next couple of months, particularly in the Northern Hemisphere as we get into the colder climates. And here's for the United States, the same thing you can see. Again, these curves really take off. One of the things that really modifies these curves is whether we continue to do masking, whether we continue to do sort of the physical distancing that we're asking people to do. I'll show you this one from California simply to show you if you can see it. There's a line here, which is the total number of ICU beds. If we continue on the current trajectory, somewhere around late January, we are going to have more patients than we have ICU beds. This is kind of a disaster. So here it is sort of blown up even further. You can see it here, the trajectory. So the next few months, as many public health people have said, is going to be the most difficult period in public health in the last 100 years. The projections are really terrifying. And I want to give you what this could look like if we don't get our act together. So what does it look like when you overrun your healthcare system? What does it look like when there are so many people in the emergency department, the wait times go from hours to days? What does it look like when you've completely filled up your ICUs? If you completely fill up your ICUs, then you can't do surgery. You can't do elective surgery, and at some point you can't do any surgery. What does it look like when you're in a car accident and you get to the emergency department and you can't come in, or you get a stick in the eyeball? These minor things, which we could have fixed in a functional healthcare system, you no longer can do. And then people get really afraid to go to work, to go outside, because there's a healthcare system that doesn't exist. Dr. Laura Wen has been on the show, and she said there's this false dichotomy out there that you either have a public healthcare system that's really functioning well, or you have an economy. But that is a false dichotomy. You must have a functioning public healthcare system, or you won't have a healthcare system and you won't have an economy. So to the non-clinicians out there, you ask, what can I do? And I tell you, you can do a lot for the healthcare clinicians that are watching tonight. And it's the basics. You just need to wash your hands. You need to do the physical distancing, and you need to wear a mask. Now, some of you are going to say that you've heard from the highest level of government that it doesn't work, that you shouldn't worry about it. Well, I'm going to say, tell me what you think about this. You're in the operating room, you or your son or your daughter or your loved one, and you're going to have an abdominal procedure. Maybe you're going to have your appendix out. Maybe you're going to deliver a baby via cesarean section, or maybe you've got a tumor. And the surgeon that day says, well, I'm not worried about getting sick from this patient, so I'm not going to wear my mask today. And the nurse says, okay, I'm not going to wear mine. And the tech says, I'm not going to wear mine. And the med student and the anesthesiologist. And for the next 2 hours, they perform that surgery on you. Your abdomen is open, and through normal conversation and normal breathing, droplets are spread. That's just what happens in our upper airway. And those droplets contain bacteria and they contain viruses, and they get shed and they're falling into this person's abdomen, this person that's you or your loved one or your friend. And then they close up the wound and it looks great. And 2 or 3 days later, though, there's a fever. And then there's an abscess. And then there's sepsis. Because the reason that those people in the operating room are wearing that mask is not because they're afraid of getting infected, but they're worried about infecting you. And if they did that, you'd probably consider that sort of malpractice, and you'd probably be right. You'd probably consider that to be immoral, and you'd probably be right. You might even consider that that act was criminal, and you'd probably be right. You know, every major religion and philosophical thought camp says basically in the end the same thing, that you should do unto others as you'd have them do unto you. That's what they all basically in the end say the same thing. You see, this virus spreads from person to person. And it's a problem because about 80% of the people with the virus don't even know they have it. And so you can spread it to the next person and the next person and the next person and them to the next person and them to the next person. And at some point, an old person will be in that line and they're going to get sick and they could die. An immune suppressed person is going to be in that and they could get sick and they can die. And even young and healthy people, for reasons that we don't understand, for genetics we don't understand, they can get ill and they can die. So think of that healthcare worker in the OR. That's you. You're not wearing the mask because you're worried about getting infected. You're wearing the mask so that you don't infect somebody else. So please wear the mask. Reduce your chance of spreading it to other people. Wearing a mask is not a political statement. It is simply one of the most cost-effective and easy things we can do to reduce the spread of this disease while we wait for vaccines and other therapeutics to come. It's a simple thing. It's the least you can do. Wear the effing mask, please. And on that note, words that Stuart uses.
I can't believe you didn't know that.
Should we do that one? Yeah, all right. So Stuart used a term this week called clinical equipoise. It's a term that I thought meant that you should slow down, you should pause when you're working in the clinical areas. But actually, it's a term that was coined by Benjamin Freeman in 1987. And it's a term that means that there's really genuine sort of thoughts out there that we don't know if this thing works, this intervention, so therefore we should study it. So unless you have clinical equipoise, you probably shouldn't do the study. For example, is there clinical equipoise in the efficacy of parachutes to stop you dying when you jump out of an airplane? No. So therefore you wouldn't do that randomized trial. But if there's a treatment, for example, like aspirin in COVID, that there is real question whether it is going to work in patients, that would be reasonable to do a clinical trial. Clinical equipoise. Words that Stuart uses that you don't know. Or you.
So before we get into the CorePendium updates, a A reminder that you can put questions in the chat on YouTube. Heidi James, who is running the chat, she'll take the best ones, the most interesting, or the ones that are occurring most commonly, and she'll put them over in a Google Doc that I can see, and we'll be talking about as we go, and certainly at the end of this. So our CorePendium updates go like this. This is the chapter. It's been accessed hundreds of thousands of times. There's a couple of things we want to tell you about. First of all, we've got 7 different languages that you can go and use if you're from other parts of the world, and this might be helpful to you in French and Spanish and a whole bunch of other things. Today actually went live intra-chapter search, and this is not just for CorePendium, but this is for everything. So if you were to go to the CorePendium chapter and like, what's the latest with dexamethasone, you put in dexamethasone, and then as you go through the chapter, it'll highlight every time it says dexamethasone. It's just a quick way to get to that information. So we thank Britt Guest and Crystal Eyes for continuing to put this chapter together and revising it continuously with a whole host of other people that are helping out there. And so without further ado, let's get our updates from Britt and what's new in the chapter.
Did a little bit of a longer version of this a couple weeks ago. So I'm just going to do some of the highlights. And as Mel said, we're going to talk a little bit more about the return to work criteria because it's changed slightly over the last month or so. With COVID, we all know that if you get infected, you make antibodies and you get some sort of immunity. How long that immunity lasts, how good it is, we're not really sure. But the next question here is, can you then get reinfected with a genetically different strand? And we don't have a lot of data on this. Honestly, all of this is based off of just case reports. But the limited data we have does suggest, yes, in fact, we do think that you can get reinfected. So this paper came out of the University of Hong Kong, and it looked at a 33-year-old male. He tested positive for COVID, and then 142 days later, tested positive again. And they did a lot of testing and genomic analysis, and they found that yeah, this was actually a different strand of COVID and not just viral shedding from his previous infection.
Well, great, Britt. We're hoping that these early reinfections are the exception that proves the rule. And the rule, we hope, is that if you're infected once, that you are going to have antibodies that are going to last for at least 6 months to a year. So now let's talk about cardiac effects. What's going on with the cardiac effects of this little bug?
So this paper came out of JAMA, and it was a small study, but it has a lot of really important information. This was a study with 26 competitive athletes, and they all tested positive for COVID. Now, the big thing here is the vast majority of them had either mild symptoms or completely asymptomatic. So very mild symptoms, asymptomatic athletes. They did cardiac MRIs on these people, and 15% of them had evidence of myocarditis on their MRI. So the next question that this raises for us as healthcare providers is, when can we actually be telling these people it's safe to go back to sports and return to play? So again, limited data on this, but JAMA Cardiology put out kind of an algorithm of how, as healthcare providers, we can approach whether or not it's safe for these patients to go back to sports. So the big thing, if you have COVID and confirmed myocarditis, so you have myocarditis, we know that, you should not exercise for at least 3 to 6 months. Before going back to sports, you have to have a completely negative workup. So normal troponin, normal echo, normal EKG. And then when you do go back to sports, you really need to do that gradually and carefully with close monitoring. So if you go through this algorithm, you've got a COVID positive athlete, and they are completely asymptomatic. So from when they test positive, they have to have 2 weeks of no exercise and then return to play very gradually, close monitoring. Go down the middle branch of this algorithm. Now you've got an athlete who tested positive for COVID and they have mild symptoms. So what do we do with that? Well, once they become asymptomatic, no exercise for 2 weeks, and then they really should get evaluated by a medical professional. That evaluation probably should include an EKG, a troponin, and an echo. If that is all negative and you don't see any signs of cardiac inflammation, then again, go back to sports gradually. Now, the third branch of this is our sicker group. They are athletes, they tested positive for COVID, and they're really symptomatic. Maybe they even needed to be hospitalized. The recommendation here is they really need to get a cardiac MRI. Again, once they become asymptomatic, 2 weeks of no exercise, and then if MRI, echo, troponin, EKG, all of that is normal, they can go back to sports slowly.
So for the ER docs, obviously, this is that Stuart Squadron thing. You need to know what you need to know, and then one step further. So for friends, family, and patients that you're seeing that are athletes, know that depending on the level of symptoms as to the level of workup that's suggested and the graded return to physical activity. It's important because this little bug, it likes the heart.
There is a ton of papers and a ton of updates in steroids. I know that during another segment of this live show, you're going to talk about treatments. So I'll skip this for now, but there's a ton of information that Crystal and I have both added to the chapter on all of these new studies in the treatment section. So I would encourage you to check it out. And one new section that we added is post-intensive care syndrome. And I think this is actually really important because I know in this pandemic, we've all been so focused on who to intubate, when to intubate, what treatments work, when to give steroids, how many steroids, what kind of steroids. But a patient's road to recovery, even out of the ICU, it doesn't just end when they leave the ICU. And we are seeing a huge amount of patients actually suffering from post-intensive care syndrome. So what is this? Basically, it's all of the mental health and physical issues that patients experience after a really severe critical illness. So, as an example, about 50% of patients who are intubated and mechanically ventilated in the ICU will develop this syndrome. Some examples of what this might look like. So each day when you are sick, bed rest in the hospital, each day of that bed rest, you can lose up to 11% of your muscle strength. So imagine you're so deconditioned after this hospital stay, you've just survived COVID, but now it's really challenging for you to just even get in your car to drive to work or drive your kids to school. About a year after discharge, almost 50% of patients are going to have mental health issues. So anxiety, depression, PTSD. And up to a quarter of ICU survivors actually become jobless and suffer some pretty financial impacts from this. So your cognitive ability to concentrate and focus is declined. You can't get in your car and make it to work. I mean, all of these things have a huge impact on your ability to keep a job, and a lot of people lose their job during this time. Geriatric patients, this is another section that we added. We know that, especially our 85 and older group, once they get infected with COVID, they have a huge increase in morbidity and mortality, and a lot of them have to get hospitalized. The problem that we run into with elderly patients is they just don't present with COVID like the normal symptoms we're used to seeing in maybe a younger patient population. So they get really non-specific symptoms. Maybe they just have some increased fatigue. Maybe they just have some nausea and vomiting that seems unexplained. Oftentimes you might not see a fever and that cough and kind of respiratory symptoms that you're used to. In terms of fever, 20 to 30% of elderly patients with serious infections actually never even mount a fever. Their baseline body temperature might be blunted, and maybe they're on chronic medications like an aspirin or something that's not letting them mount that normal fever response. So because of this, the Infectious Disease Society actually recommends using a modified fever definition for our elderly patient population. So this means one oral temperature of 100 degrees Fahrenheit or over, fever. 2 temperatures of 99, fever. And then if you are lucky enough to have a patient that you've seen maybe in the hospital or have medical records of, and you can see that just based on their normal temperature, it's up by 2 degrees Fahrenheit, that's a fever.
Okay, got it. So post-ICU syndrome is terrible. I didn't even know how bad it was. And elderly patients don't present with fevers, and they do obviously terribly. So I've got that. So what about return to work? There's been some significant changes in the guidelines as to when you can safely return to work once you've been infected.
So return to work criteria, that's the last thing we're going to talk about. And the CDC just recently made some changes to this criteria. I think it's important to talk about. So originally we had a test-based strategy and a symptoms-based strategy of how to return to work safely. And now that we're kind of farther along in the pandemic, we're seeing that test-based strategy probably isn't good enough. So let's review what that was. Originally, the test-based strategy said, if you have no fever without using any antipyretics, so no Tylenol, no Motrin, no fever, your respiratory symptoms have improved, and you have 2 negative PCR tests done 24 hours apart, that was enough to return back to work. But we're really seeing that viral shedding, even if you have a negative test, seems to go on for far longer than 1 or 2 days, probably more like 10. So this test-based strategy isn't really recommended anymore. So the symptom-based strategy is what we're supposed to use, but there's been modifications to this as well. So the original symptom-based strategy said no fevers for 72 hours, so 3 days, and you can't use, Tylenol, Motrin, no antipyretics. Respiratory symptoms have improved, but maybe not even completely gone away, and 10 days have passed since the onset of symptoms. Now, the changes I've highlighted here in yellow, now that fever, originally you were supposed to be fever-free for 72 hours, now you only have to be fever-free for 24 hours. And they changed that word respiratory symptoms improving to just other symptoms, since we know that people get a lot of GI things, so nausea, vomiting, diarrhea. They wanted to cover all of these other COVID-related symptoms. And 10 days have passed since onset of symptoms. Now, the other caveat here with that 10 days is that if you had really severe symptoms, you were hospitalized, you were in the ICU, or you're immunocompromised for any reason, they found that these patients are actually shedding virus for a longer period of time, and that 10-day of symptoms passed really should be more like 20. So those are the big changes: 24 hours, other symptoms, not just respiratory, and in our really sick immunocompromised patients, probably should be waiting 20 days, not 10. All right. So Mel, I know that was a lot. There's a ton in the book chapter, much more to come, but those are our updates for now.
Well, before we go to the therapeutics update, let me answer or try and answer a question that's come up a lot, blown up in the chat. So we did these return to athletic activity for athletes. Now, where this came from was that there was a couple of NCAA coaches that noticed that their athletes had become infected. They were mostly asymptomatic, but as they were returning to activity, a number of the athletes were saying, "I just don't feel quite right. I can't do it. I can't run as fast." And so they started to do further investigations on these athletes, and then they did MRIs. And this is where they found about 1 in 7 had MRI evidence of myocarditis. And that's where these sort of very, very conservative guidelines from the CDC have been coming from. We don't know how common that is. And so a lot of people, I think, are reasonably asking, well, I'm an athlete. I might be an ER doc, but I run, marathons and stuff. What should I do? And I think if you want to be really conservative, you'll follow the CDC guidelines. Now, if you're like me, I'm not an athlete anymore. I walk a lot, and if I became infected and then I got better, I would go back to my walking and my golf and stuff. But if you really are somebody that exercises at a pretty high level, I think you have to look at those guidelines and basically consider yourself an NCAA athlete. These are almost certainly going to change radically over time as we get more information. Of course, we don't know. Just because you have MRI evidence of myocarditis or a positive troponin, do they all resolve very quickly? Will that put you at risk for arrhythmia? We just don't know. But if you're an athlete at that level, I think you should be pretty conservative and at least go get seen and perhaps get an echo and a troponin before you get back to that ridiculous activity. You should just sit around and drink beers and do some walking like normal people. Let's do the therapeutics update. There's a lot here.
Well, Sean, I feel like we've got a tough act to follow. Even the Words with Stuart segment, I think, was very educational this time. What did you think?
I think it's educational every week. I learn something every week, and I'm sure all those crossword fans learn something every week. So you just know too many words, Stuart.
I don't know any of those words, Sean. So listen, we're going to talk about our therapeutics update in the same way that we did last month. We're going to talk about the drugs first, then the passive immunity, which is your convalescent plasma and your antibodies, and then finally the active immunity, the vaccines, right? As we have in the past, we're highlighting in the red box here remdesivir and corticosteroids because those are the two drugs that are either recommended or approved federally in the US. And we'll make sure that we know the doses of that. I want to point out that there was recently a negative study on famotidine. We're not going to talk about that, but over 7,000 patients, and because there's all that buzz, right, Sean, about high dose Pepcid. Right. No change on the chloroquine, not recommended hydroxychloroquine. We're going to talk about the several new studies that come up on IL-6 receptors, tocilizumab, and no new data on the rest. This, I should say, came as quite a surprise for us, just to set the stage, because we had just finished digesting the WHO report that was looking at all these agents, and we didn't expect this, right? They came out with a fairly broad indication for those over 12 years of age that require hospitalization, which is a pretty big group.
It
So
is.
how did this happen?
Well, I'm not really sure, to be honest. So I think that most people, when they saw we were going to do an update, were probably thinking like, hey, they're going to talk about that WHO study. And, that when people probably had heard that it was negative. And then all of a sudden out comes remdesivir with this FDA approval. So just could give a little background information. Now, we had talked about that New England Journal study a while back when we had Jerry Hoffman on. And really, that study showed the main outcome was maybe remdesivir decreased hospitalization by 5 days. And Jerry pointed out a lot of the limitations of that. And then came out this WHO study without getting too much into the details. But they started a consortium back in February and started this study in March that went all the way till October this month when it came out. And they were really large studies. And because these were really repurposed drugs, the 4 drugs that they were looking at, because they were not really antiviral drugs, or most of them weren't. Remdesivir, of course, is. And then said, let's study it. So big numbers. I mean, they did 11,000 patients, of which over 2,700 had gotten remdesivir.
Look at all the countries on there. Wow.
Oh, just 30 countries, 405 hospitals. And the take-home point, really, to cut to the chase, is there was no change in mortality if you got remdesivir. And so that study came out not too long before this approval came.
Right.
So this is quite interesting, but here we are, right? And there could be data that was presented to the FDA, and probably was, that's pre-published data that we just don't have access to. But where we stand today is the FDA approval is, as you pointed out, patients 12 years or older that are hospitalized with COVID. And the dosage is a 10-day course if you're on mechanical ventilation or ECMO. If you're not, it's 5 days, but you can always extend that out to 5 days. So people can read that. There's an official package insert. Of course, there has to be. So people can, and we can make that available to people if they want to see that.
The next thing I'm putting up, of course, is steroids. And I just want to remind everyone, nothing has changed here. The recommendations on the basis, mostly of the recovery trial, are still here. Basically, for patients that are hospitalized requiring oxygen, we're going to use steroids, and we've got alternatives to Dex if we don't have it. And so that's pretty much unchanged.
That's it. And if you don't require oxygen, it's not recommended, at least by the NIH.
That's important. That's important.
So IL-6, and we've talked about this before, this is an IL-6 receptor antagonist, and it kind of made sense. We talked about the cytokine storm, and IL-6 absolutely can be measured and be very high during it, but maybe it's just like other markers like CRP or ferritin, and it's just really just a marker, and it's associated but not causal. So there was actually 4 studies, one that was positive, but that's an observational study. There was 2 studies that we can briefly go through. So one is this New England Journal of Medicine study. This was from Boston, fairly good numbers, 7 different hospitals. And what they really showed is that there was no benefit of either mechanical ventilation or death compared to the placebo control. So that's one. The other one, and this is from JAMA Internal Medicine, and this one in particular is from France, had 9 hospitals, randomized control study, and again showed that there was a benefit at 14 days of both death and mechanical ventilation,
but not at 28, right?
But lost at 28 days. So really, who cares?
It's
then,
negative,
right? And it showed. So when we look at this, we have to say, as we sit here today, this is probably not an indicated drug. Now, I will point out both of these studies predated dexamethasone, so maybe subsequent studies could come out with dexamethasone and tocilizumab to show a benefit, but currently the recommendation is not to use this. Yeah.
I'm excited to move on to the slide that I'm proudest of. Okay. Took me a long time to put this together. But basically, I have to tell you, the story here is that Swami sent a memo on the EMRAP, on our EMRAP server thing, about this Indian study. And just on first glance, I was very upset. I was like, wow, this is a negative study. And for me, it's plasma, but that's also the same strategy for all the other passive immunity strategies. I was worried. Does this mean that, our antibody stuff won't work either? I mean, I got very upset, but now on balance, now that we see that there's this Argentinian study, it might have to do with the titers. It might have to do with the fact that the titers were much lower in the Indian study. Is that a correct read?
Yeah. So again, without getting too much into the details of the Indian study, but this was an open label randomized controlled study, 39 different hospitals in India. And what they did is they had about 200 patients that got convalescent plasma versus about 200 that got quote unquote standard therapy. They actually got 2 doses of convalescent plasma, but as you point out, they did not measure the titers before they gave it to the patients. They did afterwards, but I think that's because you raise a good question. Because if neutralizing antibodies don't work, well, that could really start pointing the fingers at other passive immunities like monoclonal antibodies. A couple of problems I have with this study is they had pretty not so robust inclusion criteria when you look at it. So that's one. But I think the big thing is they did keep some of that sera to measure the titers afterwards. And they showed that 2/3 had at least titers of 1 to 20, with a median of 1 to 40, some as high as 1 to 80. But the FDA in the United States recommends a titer of a minimum of 1 to 160. So my take home is maybe it doesn't work, but maybe the dose was just too low. They weren't getting high enough doses of neutralizing antibodies with this study. And that brings us to the Argentinian study. Now, this is, to point it out, this is a med-archive study, so it is not peer-reviewed, and it wasn't randomized, but they had fair amount of patients. They had over 800 patients that received convalescent plasma. And their inclusion criteria was a little more strict, but I think the real big take home is that they had a mortality benefit, 28-day mortality benefit of 25% versus 38% with the quote unquote standard therapy. But their titers were at least 1 to 400. And that's higher.
It's a huge difference. And then,
it is.
And once I realized that, I didn't feel as so maybe it's maybe, and it's hard to compare. Like the thing that Sean and I were talking about this earlier is, how can you compare these titers to what antibodies the people that are getting the recombinant monoclonal products are getting? Like, is it apples and oranges? And we didn't really get to an answer to that. It's kind of fascinating.
I think it is just apples and oranges, because those other ones have been studied and targeted, and maybe they'll work, maybe they won't. But I think that here you're getting kind of just a whole potpourri of neutralizing antibodies. Right. And again, I think that those titers. So I think we have to be careful with what we take away from these studies. But I think that for me, the question is still out. I really don't have an answer either way, except that I think that the higher the titers make more sense, that it may be more effective.
Right. So let's see some more data with this increased threshold. Okay. And so that does bring us to the monoclonal antibodies. And we're running out of time. We have to get to the vaccines, but there's some news here too, but not a lot of randomized controlled data.
Really, we don't have a whole lot of data, so I'm going to be real brief. There's the 2 big companies. One is Lilly. The other is Regeneron. That's the one that President Trump received. So Lilly started with 1 monoclonal antibody. They actually have a second one. So there's called bamlanivimab. It's got the study drug name too. And this was a study called the ACTIV-3 trial that we've mentioned before. That's actually with remdesivir that's currently on hold because of quote unquote safety concerns. That being said, they have a bunch of other studies going on that are not on hold. And some are giving the one first monoclonal antibody, but then they have a second one called etesevimab. And they're giving some patients too. And they have one study that's actually being given to both long-term care facility residents and staff prophylactically. So it'll be interesting to see what happens with those studies. The other one is Regeneron. Now, Regeneron is a single product, but 2 monoclonal antibodies. And both of these monoclonal antibodies are single doses. They're given one time, but there are varying doses being studied. And there's ongoing trials, both phase 2 and phase 3, including the recovery trial that we've talked about. That's a very broad one in the UK. And so far, Regeneron has had over 2,000 patients enrolled in various studies. So we're really waiting for a true randomized clinical control trial data to come out. But it's looking somewhat promising. And it's also promising because these monoclonal antibodies can be made quicker than vaccines. And so there might be a role while the vaccines are being ramped up.
We should remind everyone that in addition to the warp speed trials that we're going to talk about in a second, that there are major activities around the globe. China has a whole bunch of vaccines coming down the pipeline, both in public and private arrangements, very complicated, and it's all over the world. And of course, the Russians have Sputnik 5.
Yes.
It's funny, when you go on the website for it, they actually have a separate tab where you can actually watch a little reel about the history of the space.
All
Sputnik,
right.
the actual, but the first Sputnik. It's pretty interesting. But theirs is an adenovirus, and it's also all over the world. And so,
yeah. So I think
ahead.
it's important just briefly to mention these, because China, as you mentioned, has a number of different both messenger RNA as well as adenovirus, and have given to something like over 300,000 people. And so we might be seeing these worldwide being used a lot more broadly before the other manufacturers. But I think for most people listening, we should probably get on to the four big vaccines. So as we're looking at here, these are the ones that are in phase 3 trials. We have it as the US, but also in other parts of the world as well. And we have the 2 messenger RNA ones. So that's the Moderna and the Pfizer one. And remember to point out too, we stressed this the last time, but as you have there, these messenger RNAs require quote unquote deep freeze up until the point that you give it. So it's kind of like you pull it out of the freezer and then inject it into somebody. So not as stable, but maybe in certain patient populations like the elderly might produce a better immune response. And then we have the AstraZeneca, or also known as the Oxford, and the Johnson & Johnson ones. And those are adenovirus, kind of the more traditional ones where they have no deep freeze. So when we start looking at these different ones, and you have the numbers there, so you see fairly large numbers being enrolled. The Pfizer one, it's important to know that this is the only one being currently studied in children. So they're children 12 years and older, but they are very hopeful that they'll know if it's both safe and effective by November, by the end of next month. So we'll have to see if that will actually go there. When we look at the Moderna one, the way that they designed their study is they might not get clinical data until later because the way that they designed it. So we'll just have to see. Of course, we hope that all of these are safe and effective and get out as early as possible. And then we will look at the adenovirus one. So I think most people had heard about this case of transverse myelitis that occurred in the UK. Appropriately, the study was stopped, but restarted everywhere, including the US. And so that's just interesting. And the J&J, the Johnson & Johnson one, also was stopped briefly for safety concerns. They are anticipating, each one of these manufacturers, that they'll have like hundreds of millions of doses available once they're approved. But I think, as you pointed out, there's probably going to be the bridging with the monoclonal antibodies in a lot of different populations until that happens.
The other thing that we didn't mention was the Johnson & Johnson vaccine might differ in the number of doses required, right? There's only a single jab, and that might be logistically very important in some environments as well.
That's huge. Yeah, thank you for bringing that up, because that is the only one that's not a 2-dose vaccine. So from the Johnson & Johnson one, that is something that could, if you have people that, lost a follow-up or for some other reason.
Now, we like to finish these off with something new, exotic every time. And so I've thought of the most exotic thing I can possibly think of, which is ASA, aspirin. But we were all, of course, watching not too long ago, a few days ago, when we saw that there's actually data showing that ASA might be helpful in these hospitalized patients, right?
So we'll see, right? So the thinking is, and it kind of makes sense, right? A lot of the morbidity and mortality, it seems to be the prothrombotic complications, including the microemboli and other complications with that. So you have patients who are coming in on aspirin. So this study is actually a registry study. So, there's limitations with it, several different hospitals around the United States. But what they did is they had patients who came in who were on aspirin. And of course, most of them, if not all, had risk factors for being on aspirin. They weren't just on it. So 75% of them got aspirin within, before they got there, 80% or more within 24 hours. And then all the ones that were studied with during their hospital stay. And what they showed is that there was a decrease in mechanical ventilation in patients who received low, and this is 81 milligrams, and also decreased ICU admissions. Now, initially they showed there was no mortality benefit, but they said, well, there was confounders when they removed that. They say that there's mortality benefit. So I'm always a little cautious when they kind of do statistical analyses to say that. I think the take home is probably if someone comes in on aspirin, there's benefit in continuing it. I think, like most things with aspirin, if there's not an indication for you to be on aspirin, I think ultimately it'll probably show there'll be more adverse events than not, but we'll just have to wait for better studies. But the good news is it didn't seem to be any kind of bleeding abnormalities associated with this study. So this is just kind of interesting. It is always fun to kind of throw something out there new. This is an old drug. It's a cheap drug. And we know that it has indications for, of course, the other comorbidities that people might have. So we'll just have to wait and see.
You know, we don't think aspirin's going to be the cure, but we definitely are moving in the right direction with the passive and active immunity. I think there's good reason to be optimistic. So thanks, Sean. And,
thank you, Stuart.
And back to the team.
Yeah.
So a lot of great questions coming through, and let's just do one of them right now, and then there's a couple of other things to discuss. So somebody asked, what is the right timing for these studies, like with remdesivir and with monoclonal antibodies? We tend to be giving it to the sickest patient, but is that the right timing? Stuart, you got some words on this?
Yeah, that's an excellent question. I mean, the fact of the matter is absolutely correct. It doesn't make any sense whatsoever to be giving a passive immunity to someone who's already riddled with end organ damage and ravaged with the disease. It makes no sense whatsoever. It's just a feature of the way things shake down in these situations, that the initial patients that are treated, that are studied, were those sick patients. That's all. So you're absolutely correct. Sean?
Yeah, I would agree. You know, when these studies come out, as you mentioned, Stuart, you know, you have super sick people. So already their pre-probability of dying is pretty high. And these are kind of these Hail Mary passes that are going. And remember, this is a biphasic disease, at least a biphasic, maybe even more. But now there really is a push to target, as you mentioned, some of the passive immunity and some of the earlier antivirals early on, and then some of the anti-inflammatory stuff like dexamethasone, let's say, later on in disease. So really, everybody's learning, right? This is a steep learning curve, but that's a great question. Thank you.
And Sean, tell us about Active 3, which is one of the monoclonal antibody studies, just got stopped yesterday.
Yeah, that's right, Mel. So we talked about Active 3 in the slides right there, and we said it was on hold. But yesterday, Eli Lilly, and that's their major monoclonal antibody, and the Active 3 was in combination for hospitalized patients with remdesivir, has been shown to have no additional benefit. So that trial is canceled. The other, though, trials, Active 2, Blaze 1, and Blaze 2, are still ongoing with Eli Lilly's monoclonal antibodies.
And the big difference, right, tell me if I'm wrong, was that Active 3 was in that sickest subgroup of patients, and the other active studies and Blaze are in not so sick patients where it's probably got a better chance of working, we hope.
You're absolutely right about those. They're the sicker ones. So if you think about some of the Blaze studies, are actually in long-term care facility patients and staff, which makes sense prophylactically. So we'll just have to see what shakes out with those studies.
Okay, thanks, gentlemen. Well, let's keep going here. Now let's do some critical care updates with Sarah and Swami. She's got some new thoughts about this. How do you look after the sickest subset of patients? So let's go.
Sarah, it's good to see you. Good to have you back on EMRAP. We haven't had a live in a while. It's been a little while since we got to chat. Well, let's talk about some of the things that we're going to start. So we have the patient in front of us who's hypoxic. They seem to be failing. They're altered. They're not doing well with non-invasive. Whatever the situation is that we decide we're going to intubate the patient. Where are you starting with your ventilation parameters? Where are you setting that ventilator to begin?
Yeah. So what I've been doing after we intubate these patients is, now I just have it in my head and I have it planned out that whenever I intubate one of these patients, I am just stuck in that room for a while. Now, initially when I was doing this, I was stuck in that room for a while because I was just lining them up at the same time, just so, we could go and get it all done. Especially if we're going to prone, it just is easier to get it done the first time. So I still do that, but now I've added in an extra block of time because now I intubate them and then I go and I play with their vent. And I sort of just play this game of like, what do you want? What are your lungs like? It's sort of this like getting to know you with me and the patient's lungs game. And then I sort of do my initial getting to know you game. Then I put in my A line and then I like look at the vent again and I'm like, how do we do with that? Then I put in my central line and then I go back. And so I sort of feel like I don't do any particular thing for all of them. I usually start all of them on sort of 6 cc's per kilo and a PEEP of, 8-ish. But then from there, it can be very different depending on what the patient's vent is telling me. And I wish I could say I have a great pattern, but then the other really important period I've discovered is what happens when when the paralysis wears off. And that's the other reason that I kind of hang out in the room for a minute, because I like to see what happens right after they're paralyzed because it teaches me a lot about their lungs. But then what happens when they get unparalyzed, I have to go and reassess. So I wish I could tell you a good vent mode, but play with the patient's lungs, understand what they're doing, spend some time in there getting to know them, so to speak, is all I really can say. So I would say that I do not use a ladder that I apply to all patients. In general, I would say that the idea that exposing the lungs to 100% FiO2 for long periods of time, I don't like that idea in anybody. And I don't feel like I have enough evidence that sort of outweighs the evidence that we already have about that that's a bad idea for the lungs to say, you know what, in everybody except for COVID patients, that whole hypoxia damaging the lungs at really high doses is not a thing. So I don't feel like we have enough evidence there in COVID patients. But since we have a lot of evidence and that's a thing in most patients, I try really hard not to give them 100% FiO2. I love to keep it around 70. Now, what I do to get it there is different in different patients. And so what I will find, for most people, I just start at a PEEP of 8. And then I try and figure out, are they recruitable? How recruitable are they? And if they respond well to lung recruitment, then I try and do a PEEP titration and figure out what PEEP their lungs want, knowing this is a moving target. Then, once they're unparalyzed, I figure out, are they really desatting because they're just fighting the vent and it's not working? Do I need to paralyze them? Is that the solution? If I've tried sort of all my vent maneuvers, because I think that's a mistake we make. We're like, well, tried everything on the vent. I don't know. They're still desatting. And so, I don't paralyze them initially. I try all the tricks I know on the vent. And, those involve playing with the PEEP scale, going up on the PEEP. Is that working for me? Then if that's not working for me and I sort of can find like, okay, maybe this is about where they want their PEEP, but I'm still not getting the oxygenation I want, then sometimes I'll start playing with the I to E ratio and say, normally when we're breathing like this, our I to E is 1 to 2. Do they want 1 to 1? Do they want 2 to 1? Then I'll see, do they like APRV? If I'm just not getting anywhere, then I'm like, okay, I'm just going to try paralysis. And then if I'm still not getting anywhere, I pretty quickly go to proning for almost all of them unless I'm getting really great results right away. So I think usually between all of those things, with a lot of the patients, I can get them to a point where I don't have to have them on 100%, but not all of them. And, what our oxygen goal is, this is the thing that I really don't know. Should we be shooting for 88 to 92, 92 to 94, I don't know. I have been tending to let them run on the lower side because for me, I found that there's a lot of them that unless I just want to give them 100% all the time, I just have to accept sats that are in the high 80s and I'm just living with it. So that's what I've been doing.
What medications in general, what medications are your patients getting if they end up in the unit? And I'm assuming if the patient ends up in the unit, they have some higher level of oxygen requirement and maybe non-invasive, maybe it's high flow nasal cannula, it's CPAP, or they're intubated. So what medications do those patients, is it like almost a checklist? They're definitely getting these. I'm almost not even thinking twice about it.
Yeah, I mean, it's funny because we do this, like, in a way it kind of is like we sort of have this like, okay, everybody gets these things. Now, whether I think that everything on the checklist is necessarily definitely helping them is a whole nother question. But to me, the ones that I'm like, I definitely think it's important. Honestly, the big ones for me are simply dexamethasone and anticoagulation. Yes, we're giving people remdesivir. Sean and everybody can talk about that a little bit more, and we do it to everybody who ends up intubated, certainly. I am not entirely sure how much that is helping. The sick ones because at this point, honestly, like anybody who really ends up intubated is pretty sick because we've all developed, I mean, in my unit at least, a pretty solid threshold for just walking. I mean, there's just this like COVID wall where there's all these glass doors and just walking by and being like, 75, 78. Oh yeah, he dipped into like the high 60s. Oh, but he's like high 70s now. We've just developed this like very like Zen feeling about people sitting in the 70s all the time. So for somebody to get intubated, they're pretty sick by the time I get intubated. And I have to say, some of those people who hang out in the 70s for a week, they end up doing fine and going to the floor, some of them not. But, so most of our patients who end up intubated are getting convalescent plasma because I don't know if that helps, but kitchen sink, since we're really struggling with a lot of them. But again, the dexamethasone and the anticoagulation, because something I've now experienced, and another thing I think that maybe has changed a little bit in my management with COVID patients is my approach to anticoagulation, both in terms of my threshold for starting it and my threshold for stopping it. So my threshold for starting it has gone way down. I mean, everybody's getting prophylactic. But if they're sick enough to be intubated, unless they have a good reason not to, I'm seriously considering sort of intermediate dose. If they have any hint of clotting, anything at all, I'll often do prophylactic or full on dose. But the other thing that's come up now several times, you know, and in some of them it's come up with the ECMO patients that we have, you know, at UCLA, because we have them on all heparin protocols, but also with the other patients I'm seeing at the other place that I work, where what do you do if they start bleeding, right? Because often you're in this thing where you're like, okay, well, they're pretty sick and maybe their platelets are low and they were having some oral bleeding and maybe they were oozing from the line sites or bleeding and I had to throw a stitch in. And, you know, the other thing after a couple of experiences that's changed for me is I think, you know, in a lot of those patients earlier, if they'd been like, oh, they're just really persistently oozing from this line site, or like, oh, they're just like their gums or their, you know, we put in the NG, whatever it is. And then I would frequently back way off anticoagulation or DC it or stop it. But I've now had the experience multiple times, and maybe this is just another cluster that I'm seeing of patients who were bleeding. There was one really memorable patient actually who basically was just having this oral bleeding that like was just a nightmare to control. Like it was probably an injury from intubation and it was just bleeding and bleeding and bleeding and like just like gauze soaked in blood running out of the mouth. And so, you know, I did what I thought was a very reasonable thing to do when that situation, you know, I mean, blood is coming everywhere out of his mouth. He's intubated, the airway's protected, but even so, held the anticoagulation. And then subsequently, within a matter of a couple days later, he had a massive PE and died of his massive PE, even as his lungs were getting better. And I've had enough experiences, almost like the liver patients, you know, where you're like bleeding, but clotting, but bleeding. And so, you know, to me, I've sort of had this realization that in certain patients, I'd way rather deal with bleeding than clotting, because bleeding, I can put pressure on it. I can transfuse them for it. If I'm dealing with a massive PE, that's a whole different ballgame. So that's one of the things I think that's, for me, changed. I've gotten much more aggressive about starting anticoagulation and much less aggressive about backing it off if somebody's having bleeding that I can deal with.
All right, so everyone's going to get Dex. If they're requiring oxygen, they're getting steroids. Dexamethasone is our go-to. Great. If they're getting admitted to the hospital, we have to do VTE prophylaxis, prophylactic dose, unless they have a hard contraindication. So they had brain surgery recently. They recently had a spinal bleed or something like that.
Totally.
Otherwise, we're pretty much reaching for it. Fine.
Everybody. Yep,
The intermediate group, you're doing the intermediate anticoagulation. And is that the low molecular weight heparin BID kind of pattern?
That's the one, 0.5 BID. That's what I'm doing. Again, like, do we have firm, hard data that that's precisely the right thing to do? No. And I think also there is kind of some clinical judgment here where, you know, maybe part of if their D-dimer is super high, or also if they're just like getting worse, like their creatinine's creeping up and I don't know why, and their oxygen, and like, I don't have a specific number, but if they're just getting worse and I'm just not liking how they're looking, especially if I'm like, you are heading towards an intubation. And I don't know if that's the right thing to do or not, but that's often when I'm like, you know, I'm just going to like come up here. And pathophysiologically, you know, I think that at least now there was a really interesting paper that just came out on sort of modeling the pathophysiology of COVID, which basically concluded, I was in Nature, that concluded that it was shockingly multifactorial, but that probably this idea of microthrombi or thrombi does play at least a significant role in the pathophysiology, was the thinking. The initial vent settings, when you intubate somebody in the ED, I think it would be very reasonable to put them on, you know, 6 to 8 cc's per kilo, a PEEP of like 8-ish, 10-ish, and then, you know, for you guys, just put them on an FiO2 of 100 at first is fine. Like, you're not going to damage their lungs with an FiO2 of 100 in the next hour or two before they go up to the ICU. And just sort of while they're in that transition phase, keeping the FiO2 high just to give yourselves a buffer like you were talking about. And then I usually, with all that, I start a pretty high respiratory rate to begin with, because often they do get fairly acidotic. Not all of them, but a lot of them develop a significant respiratory acidosis. And if you start them there, I don't think any intensivist is going to be like, oh, those crazy ED people, what are they doing with the vent? Because, if you don't have the time in the ED, and when I'm wearing my ED hat, I don't have the time to sit there and learn their lungs and play with their vent for the next 20 minutes. So I think you sort of have to be like, am I in the position that I need to start some basic reasonable management? The steroids, the VTE, some basic reasonable vent settings, and then let the upstairs people sort of hash out the details. I think that's sort of the reasonable way to go.
So basic ARDS type vent settings. If you need to go to 100% FiO2 to get them into a comfortable zone, that's fine.
Start there.
Targeting 88 to 92 is great. But again, if you have lots of patients, maybe go a little higher, 92 to 94, just to give you a little wiggle room. Dexamethasone for everybody. Some kind of VTE prophylaxis, whether that is going to be the intermediate level dosing or if it's going to be full anticoagulation dosing, you can talk about with your intensivist, and that gives us a good place to start.
Yeah.
Sarah, thanks. And I'm really hoping next time we get on together, you're going to tell me, just give this one drug, everything will be fixed.
Got it. It's magic. I have the magic number, the magic drug. I'm all over it.
All right, Sarah, thanks a lot.
All right. See you later. Bye.
So a lot of great questions coming through. I think Sarah answered a lot of them as she went. One of the questions was about vaccinating somebody with flu if they've got COVID symptoms. In general, you don't vaccinate people that are febrile and still symptomatic from another disease. It's probably not very good for their immune system, but it also probably reduces their ability to develop antibodies. And then, Stuart, what about anticoagulation? What are the current thoughts?
There's a question about here about it's really hard to know when a critically ill patient is developing a PE. Do you find D-dimer to be helpful in guiding you, or do you presume they all need anticoagulation? And I wouldn't hold myself out as an expert in this particular matter, but it's very clear that that things are pushing towards anticoagulating people. And certainly we've heard Sarah and colleagues say that, if the D-dimers are 5 times elevated when they're coming in and they fit that profile, they are indeed going towards anticoagulation. Again, anticoagulation as a treatment for the COVID-19 syndrome, as opposed to for a specific indication for PE. And so that's the difference here. And so yes is the answer in general.
There was a question about outpatient anticoagulation. There's actually a couple of large outpatient anticoagulation studies that are ongoing. Tom DeLaurie talked about it in a prior EMRAP Live. We don't know yet. With the information that you told us about aspirin, I think people are going to have a very low threshold until more data comes out to send people home on aspirin for a while. So much we don't know, unfortunately. Before we get to the next segment, which is Eileen Claudius, I just wanted to do a quick shout out. We actually took a little section of a lecture she's doing for Conceptus. Conceptus is a big conference in Central and South America put on by our friends in Chile. A really important conference that's coming up 6th and 7th of November. So if you're a Spanish speaker in particular, this is a great conference to go to. There's also a lot of English language content as well, but that's just sort of an advertisement for our friends. And now let's have Eileen talk to us about the multi-inflammatory syndrome in kids that now occurs in adults.
Now let's move on to PIMS, the real heart of this lecture. So this is something that we tend to see following COVID. We don't know precisely how long, but we know on a population basis, we tend to start seeing PIMS cases about 2 to 3 weeks after the peak for COVID infections in that area. Most of the patients that go on to develop PIMS had very few or no symptoms with their initial COVID exposure, and there are several different presentations. There are the Kawasaki disease-like presentations, there are sort of the more acute PIMS presentations, and there's a kind of crossover where kids have some features of COVID as well as some features of Kawasaki disease, maybe an atypical Kawasaki type of presentation. There are 2 major definitions that have been put out for this condition. The first that I'll cite is from the CDC, and that basically requires 1 day of a fever, and it can even be a subjective fever. You need to have laboratory evidence of inflammation, and that can be any of these inflammatory markers: SED rate, CRP, ferritin's a good one, D-dimer, fibrinogen, or even cytokine levels if you have access to those. They need to have 2 or more organ systems involved, any organ system at all, and the illness needs to be severe enough to require hospitalization. Now, I think if you have a relatively healthy kid who comes in with failure in 2 of their organ systems, I think that's probably going to be severe enough to require hospitalization, so that may sort of go without saying. They need to be under 21 years of age, have no clear alternative diagnosis. If this is obviously leptospirosis or murine typhus or toxic shock, clearly that's going to be treated in a different fashion. And they have to have some evidence of COVID exposure, whether that's a positive PCR, rapid antigen test, whether it's serologies, or just a really good documented exposure to somebody who was positive. The other definition that's been put out there is by the World Health Organization, and there's a lot of overlap. The big difference being that this only goes up to 19 years of age. So if you're 20, I guess you can only have PIMS if you're in America. I don't know. That having been said, the other big and I think more relevant difference is this requires 3 days of a fever. So a little bit longer of a duration of fever before you might start working up this condition. Similarly, they require problems in 2 different organ systems, and they give a little bit more guidance in terms of what those problems are. Elevated inflammatory markers, no other obvious cause, and the same evidence of COVID infection as was required by the NIH definition. In terms of PIM-specific treatment, IVIG is really going to be the hallmark here. Some centers are adding steroids empirically. Some centers are giving steroids for patients who have contraindications or have failed IVIG. For patients not responding to IVIG and or steroids, some of these cytokine blockers have been used. So there's an IL-1 blocker, anakinra, an IL-6 blocker that I'm not sure I can say, tocilizumab, and these have been used in addition. In terms of giving something like remdesivir, typically these kids do not have an active COVID infection at the time of PIMS, and whether or not you're giving that overall is your decision, but often they don't need it at the time of PIMS treatment unless you have evidence that they actually have a concurrent active infection with the virus at that time. We need to be attentive to the fact that they may be hypercoagulable, maybe low molecular weight heparin, really moving these kids around if we can. And in the future, we may see the addition of some T-cell or B-cell depleting therapies for PIMS. Now, within the last week, something very interesting has happened, and that is that yet again, we have discovered that adults are just large children. They have reported some cases of PIMS or MIS in adults. This is the working definition that they're going by now, which looks suspiciously like the definition that we have for children. And there was recently a case report out. There are actually 3 case reports that were combined and put into a press bulletin out of the United States and the United Kingdom of 27 relatively young adults who experienced a very PIMS-like syndrome. They looked completely like these kids. They were age 21 through 50, so relatively healthy young adults that were able to mount a very robust immune response. They had sky-high inflammatory markers. They had, in many cases, a relatively minor bout with COVID in the first place. They were very highly African American and other ethnic minority in terms of the demographics. High rate of needing intensive care units. Mortality rate just above 10%. There were some strokes in this group as well. So I think that we may shortly be moving away from the idea that this is an exclusively pediatric diagnosis and really extrapolating this to people in general, many of whom granted are going to be children, that have a robust and healthy immune system to the point that they are able to mount the cytokine response, that they have macrophages that just won't stop, and that they are able to really get the type of cytokine storm going in response to probably a relatively minor bout with COVID that allows them to get themselves into this multisystem inflammatory syndrome.
So there's a great question here asking, what is the incidence of multi-inflammatory syndrome in kids? And we don't exactly have a number yet, but it's rare because there's not that many cases that have been sort of presented in the literature, but there have been hundreds of thousands, millions of kids infected. So it is rare, but it's just one of those things you've got to recognize, sort of like Kawasaki. I see that because it changes your algorithm. We're probably going to treat it much more like Kawasaki. So rare, look for it, but you're not going to find it that often. Now, a big controversy that's come up, particularly as we're going back indoors in Northern Hemisphere as things get cooler, is this droplet versus airborne spread, and a lot of controversy at the CDC about, well, is it airborne spread or not? So I got Jerry Hoffman to sort of look at a big review article on this that sort of outlined all of the data and just got his 2 cents, and he read it all and said, that's very interesting, but let's just put that article aside because I want to tell you how you really be thinking about this. So Jerry, how should I be thinking about this?
I do have a few thoughts. Let me just first say about the article. The article doesn't, this is not, it isn't something that can be analyzed the way that I, traditionally like to analyze articles, because really all it is a review. It's not there's nothing in here about a study and then we can look at the methods and do it right or not. They basically do an unstructured review of of some of the evidence that's there, and they come to some conclusions. And for the most part, the conclusions are, we don't know. They don't state it that way. They mostly state it as, we don't know, therefore we should worry. But basically what they really say is it's unproven, and I think that's sort of true. But I have to say that, Mel, that this is, to me, a little weird, all of this arguing about this, because it seems to me like we've got it on its head. First of all, there's the ongoing terrible problem of making medical questions into political questions. Just about everything we've been talking about with COVID has to do with, which side are you on? Are you on the fascist side who says go out and cough on everybody? Or are you on the progressive side which says, don't hide in your room and nobody do? This is crazy. Those are, A, they're not reasonable political positions, and B, they have nothing to do with science. So what we really should know is, what should we do based on what's our best guesses of harms and benefits potentially for whatever we do. In this case, I think there's another thing that sort of confuses me. What we usually want to do is we usually want to go from, we have an idea about how these things work, to, so what would we expect to happen? But in this case, what we actually know is, here's what's happened. And then we're going back to, well, what is it? What's the basis for it? And it's a perfectly reasonable scientific question. But what we should base our decisions on is the evidence of what we know is happening and has happened, rather than we'll take that, we'll extrapolate back to, here's the theory, and then if that's what the theory says, here's what we should do. So I don't really particularly care about which side you come down, where you come down on it. Is there a droplet, or is it aerosolized? What we should base our current behavior on is, what do we see as a response to various activities? So let's go what do we know? Because there's so much we don't know about COVID. But what we seem to know is that it's contagious. It's not nearly as contagious as some things like measles, which is clearly aerosolized and gets spread very tremendously easily. It seems to be significantly more contagious than influenza, and there are two possible reasons. One is because we have so much less innate resistance, which is, I'm sure, plays a role, but also because it spreads more easily. And so is this aerosol, is it droplet? Well, that's not an all or nothing thing. There's no question that droplets are worse. If you get coughed on while you're intubating somebody and you get a big plug in your airway, that's a bad thing. And probably even if it is aerosolized, if you encounter a very small amount over a long period of time and it gets on your tongue or gets on your hand, the chance of you getting a significant infection is much, much, much less. So it's probably somewhere in between the worst possible situation and the best. Oh, guess what? We already knew that, because that's what we see. People are getting infected. It's not like measles, but there is some evidence that maybe it's not just the people who are directly coughed on who get it, but clearly it's not massively so. So I don't think any of this really, this is not the important work that needs to be done, is to construct a theory based on what we already know.
Oh, Jerry, always with the insights and the thoughtfulness. Thanks for taking the time. I got a question here, Stuart. Somebody's asking, is any evidence that antibacterial mouthwash and nasal spray can decrease viral load and protect healthcare workers?
Yeah, actually, this is something that's been circulating around. No, we don't have any evidence for that. I wish we did, but we don't. We don't have any evidence of something that you can do like that to protect yourself, unfortunately.
It would be nice. There's some questions about using higher doses of low molecular weight heparin in DVT prophylaxis. What's happening here is that it seems that we're moving up from a standard low dose prophylaxis And now Sarah and other people are saying that doesn't seem enough. So they're talking about intermediate prophylaxis and then full dose therapy. So I think you just need to talk with your hematologist at your hospital about what they're comfortable with. But this is a very prothrombotic disease, and everybody seems to be using more and more. Look, I think we're going to end it there. I want to thank all of the faculty that were involved, everybody that was online. There were many thousands of you. Thanks for coming. We'll do this again when the time is right, and the time will be right when we have more information, when there's more randomized trials, when there's stuff that we feel that is worth sharing. Otherwise, we'll continue to update the textbook. We'll continue to send out audio and video releases, but be safe and well out there, and go Dodgers. It's the World Series. If you count North America as the world, it's a World Series, and the Dodgers are in it. So thanks, everybody. Be safe, be well, and we'll talk to you guys soon. Out.